here at the Oklahoma Historical Society
Center on the campus of the University of Oklahoma.
Oklahoma City National Memorial. I'm on the campus of Oklahoma State University, Tulsa, and here in Stillwater, the Oklahoma City Museum of Art.
And now, Generally Speaking, with your host, Dave Bialis.
Hi, I'm Dave Bialis. Welcome to this month's show of Generally Speaking. We've got an interesting topic that gets a lot of press, and it's a very confusing topic, but it affects every single American every day. And it's also a key element of the presidential campaign, and just about any topic that of substance gets to health care. So I thought we would spend a half an hour with someone in the health community that we can talk about the quality of health care in Oklahoma and what's going on in the future and how we compare. As my guest today, I have a very good friend, President and CEO of Integris Health, Stan Hupfeld. Stan, welcome.
Good. Thank you, Dave.
I know there have been a lot of talk shows, too, that have talked about this, and a lot of rhetoric and a lot of politics. And I hope in the next 25 minutes we can sort of get down to what people who watch might understand. Right. Tell me, in your mind, what the drivers are of the double-digit, almost every year, increasing health care costs to insurance companies and or Americans.
Right. Well, in the last 30 years, there's only been one brief period of time in our history where actually healthcare inflation was less than general inflation. So your question is right on target. And the answer is that there's no easy answer. There's multiple answers. If we set out 50 years ago to devise a system that was guaranteed to give us high cost, we've been successful because every element in the system pushes us to a high-cost solution. For instance, medical tort system. We have the most aggressive medical tort system in the world, and that clearly exacerbates the cost because every doctor treats every patient as a potential litigant, and so you have the opportunity for overprescribing and overtreatment. Clearly, our payment system. We basically get paid to take care of sick people, and the more we do, the more doctors and hospitals get paid. So that clearly pushes us in that direction. The way we treat technology. We have this marvelous technological system in the United States, but the fact is we have more of everything than any other country. We've often heard the statistic that we have more CAT scanners in Oklahoma than we have in the whole country of Canada. Well, that's probably true, but that also comes at a very high cost because when technology is available, it gets used. And then we have the problem of the uninsured. And that significantly adds to the price because everybody who pays for their health care through their insurance companies or through their employer or through the individual is paying a little bit of the cost of the uninsured.
So a couple questions, I guess. One, let's just do a scenario. I'm in Europe or let's say England, if that's a good example. If not, you can use any country. And I have a little slight ligament problem in my knee, but I'm okay. I'm walking around here. I go to my general doctor. They look at it. You need to go get an MRI. I go get an MRI. It says there's something there. I then get scheduled for surgery. This is all with insurance.
Right.
I then get surgery within a week or whatever. It's pretty fast here, right? What happens if I'm in England? What does the scenario look like? How's that different comparatively?
Well, every system has an effort to control costs in some form or fashion. And the way it's controlled in most European countries, the way it's controlled in Canada, that have a more federalized system than we do, they control it through the queue. In other words, you get in line. Since the technology is not that readily available as it is in this country, there's a time element. And in some cases, even time element for fairly serious opportunities. So we enjoy a great system in the country which allows us to be cared for instantaneously. If you have a heart attack this morning, you can be operated on this afternoon.
That's not the case.
That's not necessarily the case in other countries because of the limitation of resources, and you have to get in line and wait your turn.
Now, with that would come a logical question. Are they less healthy? Is their mortality rates different than the United States?
Well, that's the interesting point. When you compare what it cost us, and technology is part of the problem, when you compare what it cost us per capita in the United States to other European countries, we don't fare very well. And so when you look at the cost per capita, and then you look at mortality rates, you look at average life expectancy, you look at all those things, we don't fare very well. So the question is, we're spending more money per capita, we've got all this technology available, but on the gross statistics, how long we live and what our mortality rates are, we're among the lowest in the world. So you have to question, does the instant access to technology, is it as positive to the general health, to the public health, as one might expect?
And if you're insured, you clearly have, there's an incentive to do that kind of instantaneous work. Everything's paid for. And if you're not insured, you're not going to even go to the doctor probably and get that knee looked at, right?
Right.
And so what happens to that? What's the solution?
Well, I've always used the analogy. People need to understand, we talk about health insurance. We really don't have health insurance.
No.
What is insurance? Insurance is the payment of the many to take care of the losses of the few. So when you buy homeowners insurance, every time you get a broken window, you don't expect your homeowners insurance to pay for that. You expect to pay for that if you have a major catastrophe in your home. That's not health insurance. Health insurance we expect to use every time. It's not insurance, it's actually a transfer of payments. It's your employer paying an insurance company to pay for your medical care as you use it. So insurance is actually a misnomer.
Yeah, in fact, with in our company, it's not insurance. They process the claims.
Right.
Most companies are insured.
It's self-insured.
Self-insured, and so really it comes right out of the company's pocket. It's almost like income to the employee.
Well, a good way to think about this analogy that I've used to kind of accentuate how this issue of insurance exacerbates the use of health services and thus the cost. I have a daughter. I have two daughters, and they love to shop. And if I gave one of my daughters my credit card, and I said, I want you to take my credit card, and I want you to go to the mall, and I want you to get whatever you want. And my daughter goes to the mall, she hands my credit card to the salesperson and says, you pick out for me anything you think I need. I'm paying the bill. My daughter is the user. The decision maker is the clerk. That's our health insurance system. So what happens to the cost? Because now the person receiving the service is disconnected from the ultimate fiscal responsibility. So the person ordering the service is also disconnected. And so we've created a perfect storm. It's marvelous in terms of the protection it provides us, but it comes at a very high price. So
before the break, I guess if I can summarize, we have a system where there's an incentive to not only do it quickly, but to do almost over prescription, over treatment, if you will. There's no disincentive not to.
I think a better way to say it is that the system encourages the use of the full realm of medical armamentation,
which is technology, doctors, specialists,
that's,
surgery.
That's the reward system for the system. The reward system is doing more, not less.
And you then have the overhang of potential litigation, where if they don't do it, that could drive their costs up and out.
And then you have the problem of the uninsured, which is about 47 million Americans. And so every one of us who has insurance, part of what we're paying for is the uninsured.
Somehow they're getting treatment, but
absolutely.
Probably. Now, is this really, since mortality rates aren't really different, is that saying that the non-life-threatening kinds of things are where the costs are really being driven up versus, say, heart attacks or strokes or cancer, things like that? In other words, the example with the MRI, in some places that person would probably be fine with a little bit of pain and would taken care of in a year and a half. So that's why the mortality rates aren't really different, because we're doing so much of the non-critical at a high cost?
Well, we do, the technological solution to many of our problems is brought into question, and part of the answer is, so what would you do about it?
Yeah.
And of course, my answer to that is we've got to get to an evidence-based solution to health care, where everything we do is not driven by the incentives in the system. An evidence-based solution, and we can talk about this, basically says there are ways, logical ways to treat every kind of patient. And the whole issue in healthcare is to reduce variation. We have huge variation in how patients are treated across this country.
For the same
disease. And given that physicians need to have the ability to make calls as they see fit, the fact of the matter is when you have 300, 400, 500% differences in surgical rates from one city to another, from here to Tulsa or from here to New York, and you can't explain those in the demographics of the population, you go, how can we have that much variation? And that's what we've got to reduce, and that's why I think part of the solution is an evidence-based medicine approach, which says this is the way we treat this particular disease. These are the diagnostic tests that we order. Given their results, this is the treatment that we do. And that physicians have the leeway to vary from that, but they have to have a reason.
That's interesting. We're going to take a break. I want to talk to you about where you think the two current candidates for president, or at least the platforms, are different. I don't know if we want your opinion one way or another, but if you want, that's fine. Also, talk about Oklahoma health, because that's what you're dealing with. You've got, how many hospitals in the state of Oklahoma?
14.
14, and how many employees?
10,000.
10,000, the largest health system by far in Oklahoma. So you're the right person to talk to about the future of health and Oklahoma health, and it's not a great story. So why don't we take a break and we'll talk about some of those stats and what we can do about it. We'll be back in a minute.
Hey, are you looking for me? Oh, who could you be? A friend I can call to help me through it all.
Hi, welcome back to the show. We've got a very interesting guest today, Stan Hupfeld, who's the CEO and president of Integris Health. We're talking about health care, and it's probably the number one issue in America, and the costs and the uninsured. Right before the break, we talked about evidence-based health care, where it becomes more standardized. There isn't a variation between doctors and within the hospitals even, and the state, and that could help where things are more consistent, drive the cost down, so you don't have 20 different treatments for the same illness with different kind of specialization. But my question on that is, isn't that what HMOs attempted to do, where it was pretty standard, and that didn't work?
Well, the difference in the HMOs was that it wasn't necessarily based on evidence. It was based on what the gatekeeper thought. If you remember the HMOs, if you woke up in the morning and your knee hurt, and you wanted to go see the orthopedist about your knee, you first had to call your primary care doctor, and they had to give you permission to go get your knee looked at. And the problem with that system was, there was abuses by the HMOs, but also people were just offended that I couldn't go directly to what I wanted to do. But it wasn't necessarily based on protocol-driven evidence-based medicine. And by the way, interestingly enough, I spoke early in the show that except for one brief period of time, healthcare costs have exceeded general inflation. That's the one period where it didn't. From the HMOs. So, I mean, irrespective of the fact that we didn't care for HMOs and it offended us in many, the fact of the matter is we did drive down healthcare costs with HMOs.
Yeah. So is evidence-based your number, is that the number one thing you would do to drive down the costs? I know there's others, but is that?
I think whether you go for a Republican kind of based solution or whether you go for a Democratic based solution, there are two things that are, in my mind, are absolutely essential that I don't hear either candidate talking about. One is the evidence-based approach. I do think we've got to figure out a way to reduce variation in this country and more standardize what it is that we do, with some leeway for physicians to make individual decisions. The second thing I think we need to do is what neither candidate has done, neither party has done, and that's to ask a basic question. and that is, what do we as Americans get? And we're all talking about providing health insurance for the uninsured. We never say, what's that health insurance going to consist of? And I think unless we do both things, I think pouring more money into the system as it's currently structured will just leave us very unhappy.
So what would that look like? What would it include? You mean the coverage for the uninsured?
The coverage, basically. You know, here's the analogy that I think we have to go through, and it's not easy, and it's very difficult, but I think we've got to do it. In this country, we know, for instance, what every American gets in education, right?
Right.
That's a federal mandate. Every American child gets a kindergarten through 12th grade, regardless of your income status, regardless of your ethnicity, regardless of your race. You get a kindergarten through 12th grade education, period.
Right.
Now, it's up to the local school board to determine, you know, the size of the schools and what we pay the teachers and whether we're going to have a band and all those kind of things. But the federal mandate is this is what you get. I think we need that same kind of clarity in health care. What does every American get? Now, that's much more difficult in health care than it is in education. But we've got to get there, because just saying we're going to provide health insurance without saying at the very core, for the poorest of Americans, what does that basic benefit look like?
Because today it falls back into doing too much.
Falls back into politics.
Yeah.
It falls back. It's very unclear. You know, you've got to make, if you have limited amount of dollars that you're going to provide health insurance for the uninsured, you need to start with the question is, what are we going to buy for these people that cannot afford their own insurance? Yeah. You cannot necessarily have the same policy for them that someone with a higher income has. Just like I can send my kids to private school if I have the resources to do so, but they can also go to a public school and get a basic education. I think we need that same kind of focus in medicine. This is what every American gets. If you want to add to that because you have the income and wherewithal to do it, that's okay.
Okay, Stan, so you've talked about evidence-based, you've talked healthcare, you've talked about that there should be a definition of what, if you're not insured, what it includes. That all makes sense. What do the two current presidential candidates have in common, or how far apart are they? And just briefly, what are their two platforms on this issue?
Well, the one thing they have in common is they both call for a higher level of information technology in healthcare, to where the resources are available across a wide geography. So, in other words, I have a healthcare record that is portable, that if I get hurt in Nebraska, it can be called up on a computer and they will know what my... So both candidates are alike in that regard. After that, there's not much similarity. The Republicans, as you would imagine, basically espouse a free market solution. And the concept is that you provide your employees with health savings accounts, and that's money they can control, and because they now control it, they will become intelligent consumers. They will go on the internet, they will find out the cost of their procedures, they will determine which hospital and which doctor appear to be the best, and so they'll move the market. It's a very consumer-driven, market-driven solution. The Democrats, as you might expect, have a more regulated approach, perhaps akin to a Medicare for all. And it is interesting, a lot of people rail against government-based medicine, but of course that's exactly what we've had with Medicare, right, which is one of the most popular programs in the United States. So the two are fairly far apart on the basics, with a few similarities kind of in between at the margins. So the Democrats are looking for some more subsidies paid through taxes or through private companies? Well, I know they were talking about making the Medicare tax that employees or companies, I guess, pay right higher limits. You would reduce that. You'd have higher taxes that both corporations and individuals would pay if given the resources. They might look for some state-based solutions, such as Massachusetts has achieved, which basically requires everybody to have an insurance policy. Unquestionably, part of the solution would be if you don't provide health insurance for your employees, you'd have to pay into some sort of pool, which would mimic that, and people would get their insurance from the pool. But in essence, it would look more like a Medicare-driven program.
Are you in favor, or what do you think of Canada's? That's pretty much socialized, is it not? I mean, they pay a lot of tax, but they virtually pay for no health care.
Right.
The individual.
Right.
Is that popular? Is the health
it's
any different?
It's very popular in Canada, and I know that because I had relatives, a sister-in-law and a brother-in-law in Canada for a long time, and they thought the program was wonderful. It does come at a very high tax burden, and the question is, are we ready for that kind of tax? Canada, like the European countries, basically limits your choices because they've got much fewer technology than we have, and they have a different payment system, a different incentive system. Yeah. And it remains to be seen if that's the kind of solution that Americans would like. We've gotten used to this instantaneous health care. Yeah. But it just has come at a very high price.
Yeah, I mean, that's a good way to describe what's really going on. Let me ask you about, we'll talk about Massachusetts, and there are some models. It's working. Oklahoma Health, percent of adults who smoke, 26 compared to the United States, 19. Moderate or vigorous physical activities, 46 here, 49. Overweight, higher. I got the numbers here, but a couple points higher, including children. And then preventative, 49% in Oklahoma use or go to medical and dental preventive care visit versus 59%. Why that's the outcome? Why are Oklahomans on whole less healthy than the country? Is it education?
It probably is education. It's probably income levels. Maybe it's a lack of information. But you're absolutely correct. In every, bad behavior leads to bad health care results. So the fact is we got more diabetes, more cancer, more heart disease. The fact is that our behavior drives those results. And so we do have bad health habits, and we haven't done well. And I think part of it is, the fact on average our household incomes is less than states that tend to do better. We've got a marvelous physician community, I think excellent hospitals. But we start with bad behaviors, and everything kind of accelerates from that. And a perfect example, I chair the Fit Kids Coalition. And we started several years ago to take a look at what we were being told by our pediatricians, which was for the first time in their careers, they were beginning to see teenagers and pre-teenagers with type 2 diabetes. When my mother had type 2 diabetes, I became acquainted with the phrase adult onset. It was thought you didn't get diabetes until you were 55, 60 years old, type 2 diabetes. And here we have teenagers getting type 2 diabetes, and the pediatricians are going, wait a minute, something's happening here we're not even aware of. And, of course, the fact of the matter is that we just this epidemic of obese and pre-obese children. So the coalition began to get into that, and, of course, we've done a lot in the legislature to impact what goes on in schools, what kids eat, how much physical fitness they have, those kind of things. But we're also trying to raise the bar in terms of just public awareness so that we have a program called Together at the Table. So we emphasize families in inexpensive ways, rather than going to McDonald's, rather than going to fast foods, of eating at home in a much healthier state.
Yeah, we've got a few minutes left. Believe it or not, this flies by. Two quick answers on this. I want to ask a little bit about what's going on in Oklahoma, but how optimistic, when you hear it and you read about it, it just seems insurmountable, especially when politically they can't seem to get anything done. Mm-hmm. How optimistic, or I guess pessimistic, are they in the next 20 years? People don't realize that Medicare is going the way of Social Security. They're going to run out of money, and that's going to now be a deficit because there's the baby boomers. And how optimistic are you that we can get the parties together or the business community together and general healthcare community together to get this solved?
When I was in graduate school, I wrote a thesis, and in that thesis was about national health insurance. Now, this was almost 40 years ago. And I predicted in that thesis that in a few years we'd have national health insurance. Well, it's 40 years later. Yeah. You can see what a good prognosticator I was. and we're not a whole lot closer to it today then. So I would have to say I'm kind of guarded. I think Dave, I think there's a tipping point out there. I think things will become critical enough. We'll have, we've gone in the last 10 years from a fourth of our population to a third of our population without health insurance. And so there's a point out there when this becomes widespread enough that the middle class becomes concerned enough that you're going to have the political will to get something done. And I think we may be getting close to that point.
Well, that's, I guess, usually when those citizens form, things can happen.
Well, historically, particularly for the uninsured, when it was a fifth of the population, a fourth of the population, it was considered a problem of the poor, and it didn't have much political traction. Yeah. As that number grows, it's getting into a more of a middle-class problem. Yeah. And when that begins to hit, then I think you do get the traction necessary to do something.
Yeah, we got, I think, a minute, which is too bad because we could do this some more. But we have a cancer center going up and a diabetes. Children's Hospital is looking at expanding. Obviously, you're always expanding your facilities, but in very short, there's the Proton Center that's being built northwest Oklahoma City.
Right.
That's affiliated. What does that do, and how exciting is that in Oklahoma?
Listen, that's going to be the sixth Proton Center in the country.
Sixth.
Dallas doesn't have one. Kansas City doesn't have one. Albuquerque doesn't have one. Little Rock doesn't have one. The closest one to us is MD Anderson in Houston. We're going to have the sixth right here in Oklahoma. And the protons are a very, very high energy device that delivers high energy radiation to a tumor at a very specific site with only a fraction of the scatter and therefore the side effects that traditional radiation does. And so this company called Procure, who is our affiliate, is building this at the corner of MacArthur Memorial. We're adding another cancer center next to it. It's going to be one of the world's great cancer centers when we're done, and we should be through by summer of '09.
'09. Well, there are good things going on from a care perspective and an education perspective, but it is not going to happen overnight.
Right.
I want to thank you, Stan. This did go by fast. I was worried ahead of time whether we'd be able to cover a half an hour. We could maybe we'll do it again.
Good.
Bring on some Oklahoma health professionals and talk about what's going on there. But hopefully you've learned a little bit about the condition of health in our state, but also what the largest hospital and the head of the largest hospital thinks we should be doing moving forward to reduce our costs without reducing quality. And there are models out there. It does work, doesn't it, Stan? Thank you for joining me.
You bet. Thanks.
And we'll do this again. Thanks.
All right.
The preceding program was produced exclusively for the Cox Channel.